Thank you. It's officially 12, so good afternoon, everyone. And first of all, happy Women's Day in advance for all the amazing women out here. So my topic is pitfalls in diagnostic gynecology imaging. It's a huge topic. Let's try to cover some basic topics today. So what's the objective? Is to identify common pitfalls during our routine scans, explore advanced techniques of CT, MRI, PET-CTs, discuss advances, and of course, AI revolution. So before going into the cases as such, it's important to know the imaging options we have these days. So the most common is ultrasound, is easily available. It's one of the most commonly used first-line imaging technique. The limitation is being it's operator dependent. It means a scan done by me may be different by a scan done by somebody else because I might have used a different technique, I may use a different angle. So the images may not be reproduced exactly by the other person as well. When it comes to PET-CT, CAT scan, and MRI, the images can be reproduced, so it's operator independent. That means a scan done in HSA will be same as a scan done in doctor's hospital or health city. Ultrasound and MRI are devoid of any kind of radiation hazard because ultrasound uses sound waves. In the same way, MRI uses magnetic field, so they don't have any risk of radiation. However, CT scan and PET-CT, they use X-rays, so they have the risk of radiation. CAT scan and PET-CT are commonly used because their soft tissue resolution in pelvis is poor, so that's why they're used more commonly in staging of cancers and for recurrence management as well. MRI is a gold standard. It has excellent soft tissue resolution, so it is commonly used in most gynec case presentations. The limitation again being the cost and the availability as well. And also other thing is the MRI takes long time, so the patients may be claustrophobic as well. So what are the common pitfalls we see? So there may be overlapping features. A hemorrhagic ovarian cyst can look like a ovarian carcinoma. Endometrial hyperplasia can look like endometrial cancer. So you should be aware about all these overlapping features. And also, if the radiologist or a sonographer is not trained in pelvic imaging, so this can lead to misdiagnosis as well. There are a lot of technical limitations. If the contrast is not given, if a transvaginal scan is not done, if a proper selection of MRI sequence is not done, that can also lead to misdiagnosis as well. And you should be aware about anatomical variations as well. Sometimes a small bowel, which is close to the bladder, can look like an ovarian cyst. So you should be aware about all these things. First case I want to discuss is endometrial hyperplasia versus endometrial malignancy. Endometrial hyperplasia is a benign thing which causes the thickening of the endometrium. Usually it is diffuse, homogeneous, and doesn't have any mass kind of thing, whereas the endometrial malignancy has irregular thickening, it has inhomogeneous opacities, so it causes irregular thickening of the endometrium, and sometimes it can form mass-like features. What happens is most of the tumors, as you know, as they grow, they start to get their own blood supply, what you call as angioneogenesis. So this property is exploited by imaging. So when there is angioneogenesis, which is the new blood supply formed by the tumor itself, so the Doppler signals can be picked up. The Doppler shows bright signals. In the same way, the contrast also enhances more in the tumor because of this angioneogenesis where the new blood vessels are formed. And also the tumor cells, they have closely compact cells, so the diffusion of water between the cells doesn't happen. So this property is exploited in MRI diffusion studies. When we do a MRI diffusion study, the malignant lesions usually appear bright, whereas the benign conditions don't appear. And also, endometrial hyperplasia doesn't involve the junctional zone, which is very characteristic. However, endometrial hyperplasia malignancies commonly involve the junctional zone, and this leads to easier diagnosis. So let me show you a normal ultrasound. This is a normal transvaginal ultrasound of uterus. What you're seeing, this is the myometrium, and this is the endometrium. So whole thing is diffuse, it's clean. There is no abnormality as such in this. Here are two cases, case A and B. A and B, both are transvaginal ultrasound scans. So both have abnormal endometrium. So I want you people to diagnose which one, which. So what you have to do is, you can open your phone now, open the camera. You can click on this QR code. It prompts for a web page to open. So once you open the web page, it asks for your name. You can put some random name. and enter so that you can help me with diagnosis and we can head to lunch early. Okay, let's make it little interactive here. I showed the slide. So there are two images, A and B. Now you have to, already people have started, oh, yes. Which one is benign? Is it A or is it B? Yeah, most of you think A is the benign one, and that's the correct one. What you're seeing here in image A is that a homogeneous thickening of endometrium. It's diffuse, homogeneous, regular. What you're seeing on the other side is an irregular mass. Endometrium is irregularly thickened. It's showing mass-like features, and it has a Doppler has been put in as well. So the Doppler shows increased signal as well. That shows it's a malignant lesion. So once you're diagnosed with ultrasound, can you diagnose this with MRI now? So there are two MRI images, A and B. Both are a sagittal section, which is cut in the sides. This is showing the uterus. So that's the uterus. This is the spine here. This is the bladder here. So there are two different patients with two different conditions. So one is endometrial hyperplasia, the other one is endometrial cancer. So again, can you diagnose which? Okay, most of you think that's, okay. It's going towards 50, I feel now. Okay, before it goes, I'll change. So the first one is actually the endometrial hyperplasia. The most classical thing about this is the junctional zone. The junctional zone is well preserved in this case, whereas in the case B, the junctional zone is lost. So it's irregular, it's heterogeneous. So that's a classical for endometrial carcinoma. So if you do a diffusion-weighted MRI image, that shows bright signals as well. So both can have diffuse thickening. So you should always have a multimodality approach. It can be not sometimes tough to see on ultrasound, so then we can combine with MRI as well. There may be some challenges when, particularly with patients who are having hormone replacement therapies, so then the endometrium shows some thickening. So it's always better to have the clinical history, talk to the gynecologist, and in some cases, biopsy may be the ultimate diagnostic tool. So next is functional cyst versus a malignant tumor. Functional cysts are usually the simple cyst, like a retention cyst. They are very clear. The follicle, which is supposed to be burst in the mid-cycle, sometimes they retain, they cause retention cyst. So these are very simple, clear cyst. Whereas coming to a malignant cyst, malignant tumor, usually they have a solid cystic component, they have increased vascularity, they have thick septations, they have thick wall, and as I said, they have diffusion restriction, they have increased contrast enhancement, and high Doppler signals as well. So now you have to diagnose this one for me. So there are two images. One is an MRI, and other one is an ultrasound. Both are of the same patient. Both have same diagnosis. So again, you have to join the quiz. You just put a random name and log in. So is it a malignant cyst, or is it just a functional cyst? Or is it just an artifact, or you can't tell at all? Okay, most of you think it's a functional cyst, and that's the right answer here. What you're seeing, a very clear cyst. It doesn't have any solid components or anything inside. So it represents a simple cyst. And on ultrasound, what you can see is it has a distal shadowing. It means the inside contents are very clear. So functional cysts can be sometimes misinterpreted as tumors. So what you can do is a follow-up scan in 4 to 6 weeks, because most of these functional cysts tend to regress on their own, and they won't be seen after 4 to 6 weeks. And in case of any disturbances, a Doppler scan be done, or you can go ahead and do a MRI as well. Next is a hemorrhagic ovarian cyst versus a malignant ovarian cyst. A hemorrhagic ovarian cyst, usually typically because of the blood products, it shows a classical lace-like pattern in ultrasound. And when you do a MRI, it shows blood in different stages. So it may have the classical T2 shading, which is seen in MRI, whereas malignant ovarian lesions, as I told, can have mural nodule, it can have thick septations, thick walls, it can show increased vascularity and increased contrast as well. So here are two different cases. Case 1 and case 2, both are complex ovarian lesions. So one is a hemorrhagic cyst and other one is ovarian tumor. So can you diagnose which one is which? Okay, most of you say the first one has benign features, and that's the correct one. So here you're seeing a typical lace-like pattern, which is classical for a hemorrhagic ovarian cyst, whereas on the other side, the image B, which has increased vascularity, the Doppler is put on that, which shows bright signals. That means it's a highly vascular tumor, and as such, we are seeing a solid cystic component in this cyst. So this is a classical of it's an ovarian neoplasm. This is the MRI. Once you diagnose the ultrasound, you have to see MRI here. There are two images, again, A and B. One is a hemorrhagic cyst, and other one is a ovarian cancer. Can you say which one is which? So is it A has benign features, or is it B? Okay, most of you are, again, correct. The first one is the hemorrhagic cyst. Even though at the bottom of the cyst, it looks like a solid component, it's because of the blood products which have settled down. Whereas in the other case, there is large solid component, which is showing some contrast enhancement as well. It has thick septation, which is classical for ovarian carcinoma. So sometimes the internal echoes may be confused for ovarian tumors, so we have to do a Doppler study, and also septations or thick wall can also be confused with the ovarian neoplasms. In such cases, get an MRI done. And most of the hemorrhagic cyst, if you're sure, you can repeat after 4 to 6 weeks, because the hemorrhagic cyst usually disappear by that time, whereas a neoplastic lesion wouldn't have. Next common thing is fibroids versus adenomyosis. As you know, fibroids is a benign lesion which consists of fibrous tissue and smooth muscle fibers, whereas adenomyosis is the endometrial tissue which is ending into the myometrium. So fibroids are usually well-defined. They appear dark because of the smooth muscles, whereas adenomyosis, they are not discrete, they are diffuse. They usually involve the junctional zone. They cause the thickening of this junctional zone. So anything more than 12 mm of increase in junction zone is classical for adenomyosis. So now I told this is two images again. One is the ultrasound transvaginal scan. You're seeing a dark lesion there. And also next one is CT scan, coronal sections cut from front. So he's seeing a large uterine lesion. So now again, you have to diagnose what is this. Is it fibroids? Is it adenomyosis? Is it malignancy? Or is it a normal scan? Okay, again, most of you are correct. It's fibroids. What you're seeing is a well-defined lesion, discrete, hypodense, or it looks dark. And the one on the CT scan is, again, a large fibroid. Whenever the fibroids go so big, so usually it causes degeneration. It can be cystic degeneration in this case. It can be red degeneration. It can be calcific degeneration, other things as well. So here is another case. So it has a MRI and the ultrasound of a same diagnosis. So MRI showing uterus in a sagittal scan, and the next one is a uterus on a transvaginal scan. So there is an abnormal uterus here. So what is this? Is it fibroids? Is it adenomyosis? Is it malignancy? Or is it a normal scan? Okay, almost everyone says it's adenomyosis. Yes, that's the one. What you're seeing is the involvement of the junctional zone. It has these classical Venetian band kind of features on MRI. And ultrasound, what you're seeing, the posterior wall, which is thickened when compared to the anterior wall. And it's not like the fibroids, it's not discrete. It's actually diffuse thickening. So the junctional zone is one which has to be important in diagnosis of this. So anything more than 12 mm, you should go for adenomyosis diagnosis rather than fibroids. Sometimes the CT cannot usually show the discrete lesions. In such cases, you can do MRI, which will definitely show as a discrete fibroid. So most of the cases, you don't need any further evaluation as well. Next is endometriotic cyst versus neoplasm mimics. Endometriotic cyst is any endometriotic tissue outside the uterus causes endometriosis. It can be seen in the ovaries, it can be seen in the pelvis, it can be seen in the abdomen, peritoneum, or even in the scar tissues as well. So when they appear in the ovaries, they call as endometrioma. See, these endometrioma, because of the repeated bleeding, they form a ground glass opacities. Whereas on MRI, again, because of the blood, they have this classical T2 shading effect as well. In other hand, the ovarian tumor, as described, they again have solid cystic component, increased vascularity, and contrast enhancement as well. So this is the last one for you. So This is a patient with a right ovarian cystic lesion, complex cystic lesion. So what could be the diagnosis? Is it neoplasm? Is it abscess? Is it endometrioma? Or is it normal scan? Okay, everyone is correct here. So it's an endometrioma, which is classical ground glass opacities. So on MRI, what you're showing is a T2 shading effect, which is classical for endometrioma. So when you have a picture like this, so there doesn't need any further investigation. So we can 100% tell what exactly this is. So, but endometrioma in different places can look different. This is a scar endometriosis, which looks different from the ovarian one. It will be diffuse, it will look dark, it has some distal shadowing as well. So a few points about perfusion CT MRI. So this is something which should be genuinely used. It shows the assessment of the vascularity of the basically lesion. So it can differentiate benign versus malignant conditions. So it can reduce biopsies. So it can also help in treatment of tumors, because if the vascularity is high, the perfusion will be high. So it's a very aggressive tumor you can sell, and the treatment depends on that. And if there's a large tumor and the perfusion is less, then it says that a lot of necrosis there inside the tumor. So the treatment plan changes as well. Importance of PET-CT. PET-CT, we use it basically for metastatic workup for distance metastasis, but it is definitely very useful in other conditions to reduce biopsies. It can differentiate benign and malignant lesions. Also, it can be used for benign condition like tubo-ovarian abscesses and other conditions as well. Molecular imaging is nothing but extension of PET-CT. But we have now isotopes which can be targeted at different levels. So we have progesterone receptors, radioisotopes. So this can be targeted to detect hormone-sensitive endometriosis in the body. In the same ways, we have WBC-labeled radioisotopes, which can detect tubo-ovarian abscess and other infections as well. In the same way, ovarian aging and infertility can be detected by estrogen receptor radioisotopes. It can show how the follicles are there, and they can help in reproduction as well. And once IVF is done, if the implantation is done, to see whether the implantation is good or not, we can go ahead and do a estrogen-targeted radioisotope scan. So only drawback of all these scans is that it comes with radiation. Importance of AI. AI is something which is coming up in every field, and radiology is not new to that. So we should incorporate radiology whenever available. We have a lot of softwares now which can integrate to our routine work. So it helps to differentiate between benign and malignant tumors, and also helps in diagnosis, narrow down the diagnosis as well. And it helps in standardizing reporting as well. What's the future for imaging? As you know, artificial intelligence is the main. So there is something called as radiomics and machine learning. So what happens is the machine learns thousands of millions of normal scans and abnormal scans. And actually, it can pick up lesions what the human eyes can't see. So it can tell the cyst can continue as a tumor, whether the cyst is aggressive. So it can give a forehand before the human eyes can pick it up. So advances in MRI, as we discussed, for fusion scans, diffusion. So there is spectroscopy as well. The spectroscopy, what you used to do for brain, that can be used for pelvis as well. So when you do a spectroscopy, it actually is like doing a biopsy on the patient. So it can show what biochemical material is present inside the tumor. In case a tumor, it shows choline peak. And if it is a benign condition, it may have a lipid lactate peak and something like that. Molecular imaging, as I told, it's not only used for neoplasm, it can be used for benign conditions as well. Point of care ultrasound is something which is new, can be done on bedside, on the clinics. It has a probe which doesn't have any wire. It's a wireless probe, and the monitor can be a phone. So it has integrated AI into it. So in case you suspect ovarian torsion, you can do an ultrasound scan in the clinic, and the AI will pick up and tell the vascularity is compromised. So you can make an initial diagnosis and send for confirmation. Integration with genomics, we already have a lot of genes targeted for different cancers, like BRCA1, BRCA2 for breast cancer and other things. In the same way, now we have genes detected for benign conditions like PCOD and endometriosis. So this can be targeted, and once the diagnosis is done, you can send for confirmation with imaging as well. So what's the take-home points? So every imaging has its own benefits and drawbacks. So you should know the common mimics, whether hemorrhagic ovarian cyst versus a hemorrhagic versus a ovarian tumor, or endometrial hyperplasia versus endometrial cancer. And use advanced imaging techniques whenever available. Judicially use MRI, PET-CTs, and other things. Be cautious when diagnosing cyst and endometriosis because the treatment always depends upon the diagnosis. Whenever possible, use radiology with AI, so that will be the future. And never just compare images and come to a conclusion. Always correlate with the clinical findings, and if you have a histopathological report, compare with as well. So it's always good to have a multidisciplinary approach, and which is beneficial for all of our patients.